Hello and welcome to the Department of Psychiatry and Behavioral Sciences Grand Rounds. My name is Joe Ceramelli. I oversee the Grand Round series for our department. I wanted to say a couple of things about our Grand Round series before I introduce today's speaker. One is throughout the presentation today, I'd like to encourage you to write any comments or questions into the Q&A or the chat. I can collect those and go through those at the end with the presenter. We should have time at the end for that discussion. There is a group of us that work on Grand Rounds throughout the year and each week, including Semhar, Mike, and Charles on different aspects of the series. We have several sources of funding for this year's series, including the Ripley Fund, the Garvey Institute for Brain Health Solutions, and the Treatment of Mood Disorders Fund. That's all I'll say about the Grand Round series. And now I'd like to introduce today's speaker. Today's presenter is Dr. Caleb Bantagreen, who is a research professor in the Department of Psychiatry and Behavioral Sciences and affiliate faculty in Epidemiology and Health Systems and Population Health in the School of Public Health. Dr. Bantagreen is also the director of a relatively new center called the CEDAR, or the Center for Community Engaged Drug Education, Epidemiology, and Research, which is within the ADAI within the Department of Psychiatry. Notably, Dr. Bantagreen has spent most of his career at UW, which I want to note includes 3 graduate degrees from UW, an MSW, an MPH, and a doctorate in public health. I think that's an important point about the educational background because it might provide some ideas or motivation for people either with those degrees or currently pursuing those degrees. Now, since completing his doctorate, Dr. Bantagreen is focused on epidemiology of addiction and drug use, which with, I think, an interesting connection to public policy and the bidirectional effect and relationship between these two. One example involves Dr. Bantagreen's work as an executive sponsor on the Washington State Opioid Overdose Response Plan. Another example is on a research study, one of Dr. Bantagreen's current NIDA-funded research projects that's titled Using Data to Drive Action to Reduce Opioid Overdoses in Seattle. There's also more clinically focused research, including testing a medication-first strategy for high acuity opioid use disorder populations, which I believe we'll hear some preliminary results from a recently completed multi-site trial testing this intervention. I guess the last thing, clearly this is an area with many moving parts, only some of which involve clinical care. And Dr. Bantagreen really seems to deeply understand most or all of these moving parts and can really articulate the, measuring the problem and what to do about it clinically and from a policy perspective. I'm really looking forward to today's presentation, and thank you, Dr. Bantagreen, for presenting today. And with that, I'll turn it over to you.
Great, thank you, Joe. I really appreciate that introduction, and I really appreciate everyone showing up and spending an hour. I'll give a presentation, but I certainly would love feedback and thoughts and questions, and then I'll share some of what we do and some of the challenges that we're facing in this work. And I think just to start with that background, I do have maybe a somewhat atypical educational background for our department. I'll share that, I did an undergraduate degree at University of California, Santa Cruz in biology and immunology. Was an HIV counselor and educator there. In my social work training, worked both, my first internship was at an opioid treatment program, which was actually my last choice because I knew I wanted to do research. And they said, too bad, you need to go do clinical work. And I could not be happier for that. It was a fortuitous turn of events. I did my second practicum was at the VA doing medical social work, which was a great experience as well, in a very different care system. And I think important to see how those different care systems work. And then while getting those degrees and wrapping them up, I did an RA-ship at ADAI, and I'll share one of the first papers that we did there. Worked at ADI for a few years, went and worked at a National Child Welfare Agency doing some policy work for a couple of years, and came back to ADI in 2001, really to take on a drug epidemiology project, which I'll explain some of the context of. And a few years into that, worked with Don Towson to get an R21 from NIDA while I still had my master's degree, and that really motivated me to go back and get my doctorate, which I did, completing that in 2008 in health services research here in the School of Public Health. So just a little bit about my background and some of my experience there, and that trajectory, which is perhaps not quite as typical in our department. But I think that broad scope, this idea around social work and understanding the clinical context of people's lives and public health and research and taking things to scale, that really does underpin how we approach our work. I definitely want to acknowledge that, as we gather today, we are in the ancestral homelands of the indigenous people who have lived on these lands since time immemorial, and I hope you'll join me in expressing our deepest respect and gratitude for our indigenous neighbors. I have no conflicts of interest to report. I do not accept funding from pharmaceutical companies, and I mention that because I will be mentioning a few medications. My current funding includes several contracts with the Washington Healthcare Authority, the Division of Behavioral Health and Recovery. There are some projects we work on there that are essentially pass-through funds from DHHS or SAMHSA, and others are Washington State on contracts with state agencies with various state funds. I'll describe some of those projects. I'm fortunate to have some funding from NIH, the National Institute on Drug Abuse. I'm co-PI on a grant that I'll describe a bit of with Julia Hood, who is an epidemiologist at Public Health Seattle King County. And I'm a co-investigator on a couple of projects with Lauren Whiteside in emergency medicine and with Susan Ferguson, the director of ADAI. And then I'll also be mentioning some about a large project we've been working on that Joe alluded to around our multi-site trial from the Paul G. Allen Family Foundation. So my goal today, I want to introduce our CEDAR team and our partners, really get into why we do our work the way that we do it. I'm going to give 4 examples of our work around low-barrier buprenorphine and harm reduction programs, a co-design project with law enforcement and people who use drugs that my colleague Mandy Owens leads, our Washington Community Drug Checking Network. I want to tell you about our Washington Treatment Research Work Group, which you are very welcome to join. Just orient you to our webpage and our online resources, and then if we have some time for some questions and discussion, that would be lovely. So for our team, we are a big team. We had our team meeting this week and we had 8 folks on site and 8 remote, and it was very heartening and exciting to see all these folks. Not long ago, we were 2 or 3 people, so pretty rapid expansion. So I direct our center. Ben Beaumont is newer to working with our team, came on last year, and he oversees the day-to-day operations of our community drug checking network. And he comes from Portland, where he worked in both nonprofit and governmental syringe services programs, and just brings a really great perspective and knowledge and really important relationship building with our community partners on that drug checking network project, which I'll describe. Leilani Don is a certified peer counselor. She actually works out of Spokane. She actually works half-time as a care navigator in emergency department there on their buprenorphine work. She also works for us as a trainer on care navigation for our state opioid response, opioid treatment network work. And she's also a drug use health expert on our NIDA grant as a person with lived experience and a history of using treatment medications herself, and just brings powerful insights to that project. My longtime colleague, Anthony Floyd, we both came back to ADI more than 2 decades ago. Anthony is a sociologist, and he's an associate research professor in the department and works very closely on our various trials. Susan Kingston is our manager of program operations. She has decades of experience in harm reduction, both domestically and internationally. As our manager of program operations, she's really kind of the glue of our projects, and also helps a lot on our communications side, both sort of externally facing as well as really thinking about appropriate language for materials as we build them for folks who use drugs. Rihanna McPhee is a continuing education coordinator and works with Mandy Owens on the CLEARS project, working with law enforcement partners. I'll mention a little bit about that in a moment. Allison Newman is a program operations specialist. She's been with us several years. She's really the labor and the effort around our stopoverdose.org webpage, as well as a bunch of other activities, including more recently getting involved in some of our qualitative research projects. Mandy Owens is an assistant professor in the department, a clinical psychologist, also has clinical work here at the UW, and is building up a nice portfolio of research projects and implementation support that are really exciting. Jason Williams is a research scientist, does a ton of both our data analysis and what you'll see today, some of our data visualizations, and he's an amazing partner to have. Wendy Williams Gilbert is a nurse consultant based out of Spokane, has an extensive history in critical access hospitals, and has been helping on our state opioid response training and technical assistance with healthcare primary care providers, emergency departments in particular is a main emphasis of her work, and she's actually doing some clinical work in emergency departments as well right now, which has been really valuable. Teresa Winstead has been working with us for a couple of years as an anthropologist and has really been incredibly helpful with us on our qualitative research projects. And we're working with her now as we do more implementation research to bring strong qualitative methods into that. Kelly Youngberg is our Assistant Director for Healthcare Strategy and Implementation and has just been very important. It came from the AIM Center, helping us oversee our state opioid response training and technical assistance, but also a lot of our work around sustainability is moving into understanding the healthcare financing underneath these models. I won't go into it a lot today, except to say that a lot of the models that we are using, the bulk of the work is being conducted by either nurse or mental health care managers and care navigators for whom it can be very challenging to get reimbursement. So Kelly's doing a lot of work on that side. Mandy Sladkey is a nurse consultant and working with us both on training and technical assistance and really on our NIDA grant, which I'll describe, helping us build out our medical protocols, which has been very exciting. I'll mention 3 graduate students who are working with us. Adam Paliu is in epidemiology, has particular interest in work around models of safe supply and population size estimation. Saul Petersky is a social work practicum student, really excited to have somebody come alongside us who is going to work us on adapting our syringe service program survey into permanent supportive housing programs and working with clients there to understand components of isolation and how they impact overdose risk. A lot of folks are dying alone in their rooms in permanent supportive housing. And really, there's an important opportunity there to provide good service and help folks out. And then Samyukta Singh, lastly, but not least, is a doctoral student in health services research working with me on several things, including looking at trajectories of opioid use disorder by whether folks are using fentanyl or heroin. And then I'll note, hopefully you can see this already. I know you can't see folks' pictures, but I will let you know we have a really diverse team, and I'm really proud of that, and it's essential to our work. They come from different economic backgrounds, different academic backgrounds. We have diversity in terms of race and ethnicity, gender identity, and very important, having folks with lived experience of substance use and incarceration is really essential to not just doing good work, but also, walking the talk about actually, people do recover and they can restore to function and they can really be essential partners in the work that we do. So that's a lot of time with that group, but it's really important for me that you know who's underneath all of this really important work that I'm going to share with you. So our community partners, they include researchers and clinicians all across the University of Washington. I feel very blessed to be here and just incredible colleagues here and working with folks in the department long before ADI became part of the department. Also working with other academic and science institutions. I just got off a call with the National Institute on Standards and Technology. We do a lot of work with WSU. We're doing some work with UNC, UCLA, San Francisco. So a lot of nice partners out there. State agencies, we primarily partner with the Healthcare Authority and the Department of Health. And if people aren't familiar with Healthcare Authority, you might think of that as both the Division of Behavioral Health and Recovery and also our state Medicaid program. Professional organizations, Hospital Association, Addiction Medicine, Sheriffs and Police Chiefs, the State Criminal Justice Training Commission. We do a lot of work with those professional partners to help disseminate work. And briefly, community agencies and partners across the state, really excited and honored to work with harm reduction programs, service providers serving folks who are unhoused and or in supportive housing, diverse addiction treatment programs, primary care, health departments, hospitals, jails, first responders, healthcare payers, just a really rich network of folks that we're really proud to work with. So why we do the work that we do? I have a few slides here I want to share with you. So like all of you, we value people's diverse experiences and recognize that context informs meaning and behaviors. And in the context of substance use disorder, particularly with illicit substances, inequity, trauma, stigma, and marginalization are the norms for people who use drugs. And so to address this, we do qualitative work with people who use drugs and the providers and stakeholders to understand the context of people's lives. My very first product when I was an RA was working with Mike Gorman, who's a medical anthropologist, to understand the extremely high HIV risk among men who have sex with men and inject methamphetamine. And as a very newly minted social work student, I got my skills quickly put to the test in doing 2 to 3 hours semi-structured interviews with folks who had methamphetamine use disorder. It was an amazing project and really helped ground me and understand that treatment is definitely not a one-size-fits-all, that identity and culture and those aspects are really essential to incorporate into care in order for it to be meaningful for folks. Fast forwarding 25 years on the right side here, this is an example of a really beautiful flyer, a little piece of one that Allison Newman put together based upon qualitative interviews that we did with 30 folks who use fentanyl, where we wanted to learn more about their experience of fentanyl use, the meaning it had on their life, and what services they were interested in generally, and also that they thought would help address their fentanyl use. We value science. And we know that decision makers mostly respect and occasionally act upon data, and they tend to really focus on quantitative data. My staff will tell you that my #1 phrase is, our job is to document the obvious. Nothing convinces a lawmaker like a pie chart. So we conduct epidemiology, clinical trials, implementation research, and secondary data analyses. And we share our results in really diverse ways. We have multiple web pages I'll share with you. We put out over 100 reports over the last 20 years, and also, of course, peer-reviewed manuscripts. And just a couple examples here. You know, the one on the left here is around a provider learning series. We did around medications for opioid use disorder for adolescents, which we've actually re-energized recently and getting very good attendance there, which is really exciting. And then the article here I mentioned on the right is on the impact of a jail-based treatment decision-making intervention. And this is one where we took a shared decision-making approach and worked with jail staff who were doing reentry work for folks with opioid use disorder to educate them about their options around medications for opioid use disorder, and found that this brief intervention more than doubled the chances that folks would start medications within a month of getting out of incarceration. So really exciting, very high impact findings. And again, to that, we really value real world impact. And in that attempt, we really work to engage in dissemination, implementation support, do a lot of media interviews and a lot of policy work. I think people like to give me a hard time about how much media work I do. However, I think that you know, one article in a newspaper may have more impact than 3 research articles, just practically in our community. So I do both of those things, but I do find that media work can be quite important in terms of spurring people into action. Our faculty, staff, and students serve on local, state, and federal committees. I'm really excited about that. I'm really excited to see those opportunities. I'll share that Mandy Owens testified for the first time in front of the state legislature last year. She memorized her testimony, which I had never done, and she was amazing. So just really neat opportunities for folks to get chances to directly influence policy. And we work with UW government relations very carefully and in a coordinated way to educate legislators and inform policy. And there's some examples here. These images here is an editorial I wrote last year for the Seattle Times, and some meetings we've been having with the governor. This is actually several years ago, but he had a recent roundtable about a month ago that I was happy to facilitate around fentanyl, again, with really diverse partners. So this slide, I hesitated to put it in, to be honest, but in some ways I think it's the most important slide and one that I'm really grappling with. We're doing hard work. We are trying to push the envelope and grow as a group. We're trying to do work that is more meaningful, more transparent with our community partners. And guess what? We make mistakes, and we do our best to learn from them. You know, the real world is very messy. Our work is messy, and we make mistakes. We try to acknowledge those mistakes and learn from them. And I can't impress enough how sort of genuinely and meaningfully working with, listening to, and incorporating the experiences of people who use drugs is essential, and it's hard. And we're still learning how to do it. I think you all would share this with me, but you know, our scientific methods and the University of Washington and our funder bureaucracies and timelines can be huge barriers to try to overcome. And recently had a really challenging interaction with a longtime partner who I really value, and really realized in reflecting upon a very difficult interaction that I was using the word constraints. We have these constraints. We can't do this, we can't do that because of these constraints. And it was really infuriating to this partner and really ignited in them a passionate and very well-informed rebuttal. And I think what I really took away from that is that they were hearing constraints as just another excuse for inequitable decision-making. And I don't have the answer to that. The best I can do is try to start the process earlier, try to be more transparent, listen more, and do my best to try to really work with, push back on funders to allow enough space and time at the beginning of projects to really genuinely join with our community partners. So this is essentially our mission statement of CDR. We try to join research with the real world to generate innovative, evidence-based, and person-centered responses to the use of opioids, stimulants, and other illicit substances. And our goal is to collect and share knowledge gained from research, local data, clinical expertise, and personal lived experiences of people who use drugs. And this knowledge is used to improve policies and services to reduce substance-related harms and improve the lives of people impacted by substance use. Acknowledging that equitable access to relevant and effective care is necessary to address current and historical policies that create inequitable harm to people who use opioids and stimulants. We are actively working to improve the diversity of our team, students, and partners, and strive for inclusion in all aspects of our work. We primarily focus on opioids and stimulants. We have wonderful partners here at ADI who work on areas of alcohol and cannabis. We've also worked in those areas. Right now, we're primarily focused on opioids and stimulants. And our work is primarily focused again on adapting, implementing, and evaluated evidence-based interventions and harm reduction and other community-based settings, as well as care settings such as jails, emergency departments, and substance use disorder treatment programs. We've worked with and certainly continue to support folks working in primary care settings and other settings, but we tend to work more out in the community. We have a statewide scope, and I'll note that that draws from community epidemiology work group processes and reports initiated back in 2001. Joe asked me, like, how do you get into drug addiction epidemiology? In a way, as you get hired into it, I took over a work group in Seattle that was a NIDA work group that had a long history, a drug epidemiology work group. And what I'll say I learned from that process, that work group had a dozen people. It had people from the DEA, it had people doing street outreach, it had people from public health, it had substance use disorder professionals. It had really, really diverse perspectives. I then took that work group and expanded it to 12 other counties and went on the road. And that was a challenging but really important process, and I still have many of those relationships intact. And so that orientation with a statewide approach with diverse stakeholders is something that really has been baked into my work for a couple of decades now. And now we see this with some of our other products. With our current projects, contracts with state agencies for both service and implementation support. SOAR is the state opioid response, opioid treatment network support that we're doing. SSPs are the syringe services programs, and I'll mention that in the context of the CDCN, which is our community drug checking network. So before I go, I'm going to just pause for a moment and see if Joe, if there are any questions or comments so far.
There was one comment regarding partnerships about child welfare, if that's part of, yeah.
Great question. So it's a good question. We have not done a lot of work directly with child welfare. We have had some conversations with them for sure in our executive group. Some of the child welfare folks from DSHS are part of those conversations. And I certainly work a lot with my colleague at ADI, Susan Stoner, who oversees the Parent-Child Assistance Program. And also conversations with folks like Celestina Barbosa-Leiker at WSU. So it's not our primary focus, but we definitely try to provide support and services for folks who are working in those systems. Okay, so just for a bit of context, I'm just going to throw up 2 data slides and that's about it. We use multiple data sources in our epidemiology work. One of the primary ones is mortality data, overdose data. And we do that because it's basically one of the only real population-based data sources that we have. And we actually have pretty detailed information from the chemistry that's done to understand which substances are present. And we have some reasonable information, imperfect and often missing, around demographics and geography. So they can be quite rich data to work from. And also, it's the thing we're trying to avoid. So working back from and understanding overdose deaths is one of the ways we approach our work. I will also note, you know, in some ways, you know, we're really working to help keep people alive. The converse piece of that is just as important is also trying to do the work around how do we help people have lives worth living. And that in some ways is a more challenging endeavor. But what I will note here for context, this is looking at the rate per 100,000, so this is adjusted. The overdose death rate, that black line, is up profoundly. It is more than doubled in a decade. And what you can see is why. The red line is opioids. I won't belabor it now. It was pharmaceutical opioids, it was heroin, and now it's really illicit synthetic fentanyl products that are driving that. What's interesting and very concerning is the huge increase we're seeing in methamphetamine-related overdoses, that next line down. And, all of the talk now is about fentanyl. There's very little talk about methamphetamine. But what we're seeing with methamphetamine overdose deaths, and we know in this department pretty well the challenges around treatment, is profound. About half of those methamphetamine overdose deaths involve opioids, and about half involve no other substance. And if we weren't talking about those things, we would see this line at the bottom, which has actually increased dramatically, which are cocaine-involved overdose deaths. So just noting, one of the reasons that we focus on opioids and stimulants is this profound mortality that we see. I also want to note profound racial disproportionality in the impact. On the leftmost side here, you're seeing American Indian, Alaskan Native folks, and you're seeing a much higher rate at baseline for overdoses compared to white non-Hispanics in green. So more than double the rate. And you can also see more than tripling of that rate in just 4 years. So these are just profound disproportionality in the base rate and in the acceleration in the rate. We see somewhat lower but similar pattern among Black non-Hispanics, and then you can see the base rate here among whites. So there's grave disproportionality happening in these overdose deaths. So this is a complicated slide, but I want to walk you through it, and it's really important. I want to give this example around low barrier medications for opioid use disorder and how this work has evolved over the last decade. In 2015, we hosted at the Hub an opioid overdose prevention summit. My former colleague, Michael Botticelli, who was the director of the Office of National Drug Control Policy, was the keynote there. We had about 400 people on site for that summit, and the energy in the room was amazing, and people were really excited. And we had a few folks come over from Eastern Washington, like, we really need this in Eastern Washington. So I don't really know how, except I'm pretty sure it was Susan Kingston. We somehow pulled off 3 months later, hosting another meeting at Central Washington University where we had 200 people in Ellensburg. And what was important in that partnership, is those meetings were co-hosted with the U.S. Attorney for Western Washington and Eastern Washington, which really broadened the stakeholders who came to that meeting, which I thought was really quite important. We also heard at that meeting the need for more local data. And so with that, we took that as a catalyst to launch a first-time statewide syringe services program survey. King County had been doing syringe service program surveys for almost a decade at that point, and I've been lucky to partner with several graduate students in analyzing and publishing on those data. And those are brief client surveys. They're a 5 to 10 minute street intercept survey, asking people about their substance use demographics, injection characteristics at the time, consequences of use, and interest in services. So we expanded that statewide, and we now do this every other year. We usually get between about 1,100 and 1,300 folks at about 20 syringe services programs. We're just wrapping up surveying right now. I think we're going to get even more than that. What we found in that first survey in 2015 was that 80% of people said they were interested in stopping or reducing their opioid use. 70% of them said they were interested in methadone or buprenorphine. And 60% of people said they needed health care in the last year and not gotten it, primarily because of how they were treated by providers. So I had that in the back of my mind. At the same time, I had my first NIDA R01, which was a behavioral intervention, an overdose prevention education intervention with an offer of naloxone that we did primarily in a Harborview emergency department. We had a non-significant reduction in overdose, 18%, but essentially we had a null effect. So I was hearing people want to stop and reduce their use. They want medications. They're not able to access care in primary care settings oftentimes, and yet they're getting services at syringe services programs. And then I have this big trial that I've just completed that is saying, guess what? Doing a brief intervention in an emergency department around overdose when people have untreated opioid use disorder is not very impactful. So just putting one and one together, put together a proposal for the mayor's office in Seattle. Why don't we offer buprenorphine at syringe services programs? And we worked with Public Health Seattle King County, and Brad Feingood is an amazing partner there, and he was able to fund a nurse case manager. And in January 2017, buprenorphine pathways launched down in Belltown. And that program was at capacity within 12 weeks. And within a couple of months, people were lining up 2 hours early to get treatment medications. So The feasibility and acceptability was profound, and we also saw significant reductions in illicit opioid use and very high utilization of buprenorphine. So really exciting. I will also note that we found those results even as we weren't directly impacting methamphetamine. Methamphetamine use did not change in a relatively short period of observation. Other folks, such as Dr. Judith Suey in a primary care setting, has seen methamphetamine remediate. We did not see it in a setting. So that's an interesting finding, something we definitely will dig into more. With those preliminary results, and we published a nice paper together, Julia Hood and a nice team from Public Health Seattle King County around those results for the first 150 participants, was able to meet with and propose to Paul Allen in the same year, unfortunately, of his passing, a project to try to replicate those results. We were really excited about the results with the nurse care manager model. We wanted to really facilitate broader access into primary care, which they had struggled with. So we added to that nurse care manager model care navigators, and we wanted to replicate it in 6 sites. And we included in those sites Walla Walla, Spokane, Centralia, trying to get more diversity, because what I committed to trying to do to Paul Allen was to try to create a national model quickly. The pitch was, you can help us do more quickly than NIH can, replicate this model and try to create some variability and generalizability for a national approach. So we did a 6-site replication study, presented the results at the College of Province of Drug Dependence in June. I committed to Joe that I'm going to get that manuscript submitted by Sunday. It's basically done, but I'll share with you that what we found was a profound uptake in buprenorphine and a significant reduction in mortality. A significant reduction in mortality relative to a comparison group that also was matched on history of opioid use disorder treatment with medications. So we're really, really excited about those results. We took that model around low-barrier buprenorphine, or medications first, we called it, and expanded it to address stimulant use. We now are calling that health support teams, almost version 3.0 of this model. That model, looking at what New York State has done around drug user health hubs, we had a Washington State Substance Use Recovery Services Advisory Committee. I was the co-chair of the treatment subcommittee, and we worked with diverse partners to build a health engagement hub recommendation, which is a very similar low-barrier, community-based approach, really focused on harm reduction programs, offering a nice array of services on a drop-in basis to folks. Side note, that's why it's in brackets here, I'll mention, we have a NIDA study to build an opiate overdose recovery and care access center that had initial funding in 2022, and we're waiting word for our continuation funding, hopefully in the next week. I'll mention, though, what we've done in the meantime is continue to conduct multiple studies to understand fentanyl use and this notion of ideal treatment. In 2023, this recommendation on health engagement hubs was funded by the Washington State Legislature. They funded 2 pilots. Department of Health put out an RFI that's being under review right now, and there are active conversations with the legislators right now to expand that health engagement hub, hopefully to 5+ more models. I'll mention that the SERSAC committee recommended 39 health engagement hubs, and really looking at a 3rd model of care alongside office-based opioid therapy, opioid treatment programs, really seeing a 3rd model of care that's this community-based drop-in model. I'll mention that in parallel with this work and resulting from it, we have extensive reference materials on our webpage, learnaboutTreatment.org, around low-barrier medications for opioid use disorder. And we really try to give some information on this webpage. This is within our professional section about, what is the goal in this work around creating this new model, what our strategy is, the rationale, and then just as I said to you, what motivated this? Why do we do this? And then underlying beliefs core to the model, which things are probably pretty familiar to you, but I think are really important to get out to the more general public. Opioid use disorder is treatable, medications are the front line, people will get better, relapse is expected, and language matters. I think one of the things that is still always a challenge is, how do we kind of codify harm reduction? Do we call it harm reduction? Do we not? How does trauma-informed care overlap with harm reduction? How do we make sure that that's integral and emblematic in this work? So we're really trying to explain this. We have more details I'm not going to go into now about the hallmarks of a low-barrier buprenorphine program, showing some of the research both ourselves and others work in this area. And then we have different presentations we've done over the years around the model of care. I'll also note that this model has been incorporated into the state opioid overdose response, this opioid treatment networks, as one of the models and requirements is to do a low barrier approach. So this is expanding as a model both within the state, and we're having some conversations at the federal level as well. Folks may have seen some SAMHSA guidance in the last month about low barrier approaches. So we're excited that the work that we are doing and others are doing is really kind of catching hold pretty quickly. I do want to pause there for a moment. I see there's another thing in the chat, Joe. Is there anything at this point that would be worth clarifying or responding to?
Caleb, that was just me encouraging participants to write in questions or comments.
So it's a comment on the need for comment. Great. Okay. Thank you. I want to mention another product, which is the CLEARS product. This is led by Mandy Owens, and this is the Community Law Enforcement Aligning in Response to Substance Use project, funded by the legislature in contact with the Healthcare Authority. And it's really exciting product. And I know Mandy's learning a lot, and I'm learning a lot from her experiences, really doing a policy co-design process to bring together local law enforcement with folks with lived experience. And the goals are to develop regional solutions to improve interactions between law enforcement and people who use drugs, to develop materials for future regions to engage in similar co-design processes, and to learn how participants feel about that process. And they've gotten a second phase of funding and are adding new sites right now. I'm just showing you here kind of a high level. You can see one of their meetings here, one of these large meetings they had. You can see some of the online materials they've created. Mandy's partnering with our colleague Jenna Van Draenen, who's in nursing and in public health. And his product staff, just to share with you, is really important. It's folks with lived experience of substance use, lived experiences of incarceration, as well as law enforcement folks. Our colleague and a longtime partner, Malika Lamont, who works with the Council on Expert Advisors of Drug Use as a consultant on this project. And then Jenna Van Draenen is someone who also works and helps facilitate the research expert advisors on drug use. And the goal there is to have formal ongoing processes where people are paid to provide their expert guidance on both public health programming, community programming, as well as research activities. So that's a really exciting project I encourage you to take a look at. So I see there's something in the Q&A in the chat. I'm trying not to look at that, but I see the numbers are up there. Can you tell me if there's anything, Joe?
I will tell you, Caleb, it's yeah. From Paul Grecken.
Yeah.
How often are fentanyl or other opioids present in stimulant overdoses? Has this changed in time in proportion to stimulant overdoses generally? Yeah.
Thanks, Paul. It's been relatively consistent, and I say this, but between 40 to 60% of methamphetamine overdoses involve an opioid. Historically, over 10 years ago, was really heroin, and it's now really fentanyl. I'll also share with you what we're seeing. There's often a lot of concerns around this from our drug checking network data. We're not seeing those drugs oftentimes mixed. We've done other work, which I was not planning on sharing today, about why people use those substances together. And Paul is the medical director of an opioid treatment program, knows this better than I. But there are reasons that people use those substances together, obviously. And they often have to do with sort of counteracting the stimulant and depressant effects and also the duration of effect of those drugs. So there are some complicated reasons there, but they've often been combined. And my friend and colleague Ron Jackson would point out, even 25 years ago, of course, we really talked about speedballs, cocaine, and heroin. So it's not an atypical thing for people to be mixing those stimulants and opioids together. So on that note, I'll mention a little bit about drug checking. This is a really exciting newer project we have. And the goal, first and foremost, is this is a harm reduction program, first and foremost. This is maybe atypical, but we're really helping support services. That we're trying to help people who use drugs make better informed decisions about their drug use and reduce risks of overdose and other health consequences. Important intended secondary goals is we want to provide accurate, up-to-date information about the drug supply to local stakeholders, including healthcare and drug treatment providers, first responders, and public health. It's very important for folks to know, are those fake Xanax bars, what's in them? Is it actually alprazolam? Is it atizolam? Is it bromazolam? It's generally not alprazolam, but it's another benzodiazepine of rough equivalent potency. So that's an important piece of information to know. It's important for people to know, obviously, with the clinicians here, whether a person is benzodiazepine dependent or not, if you're engaging in healthcare or substance use disorder treatment. So we're trying to also provide that additional information out of drug checking. So our network is a partnership of organizations around the state that provide community level drug checking and related harm reduction services. I will note that one of the reasons I'm excited around drug checking is it is yet another harm reduction service. It's yet another reason for people to come in. We really started getting going on drug checking before Washington State last year legalized some more paraphernalia around smoking supplies. So both smoking supplies, smoking is now predominant over injecting for both methamphetamine and fentanyl, as well as drug checking services are other reasons for people to come in. There are other reasons for engagement. I won't belabor it too much today, but to me, engagement is the goal. And so in our service delivery for folks who are actively using drugs, having harm reduction is the service that basically everybody wants. And thinking about it as an end in and of itself around overdose and infectious disease prevention, but also an opportunity for engagement and relationship building. So that if people are interested in other services over time, there's a foundation of a therapeutic alliance and a relationship that people can build upon. So our job here, and working with Ben Beaumont and also Jason Williams on the data side, and Susan Kingston's also working on this product, is providing technical assistance, training, and ongoing operational support to the network. And we're also partnering with Public Health Seattle King County. They actually funded 2 sites slightly before we got started. I'll also share for context, the community drug checking, really, we're about 3 years behind where the East Coast is, and it actually kind of logically and is interrelated to the 3-year lag of fentanyl hitting the West Coast. So they're interrelated phenomena. I'll mention right now we have 7 full sites, and these full sites use immunoassay test strips or test strips for fentanyl, xylazine, and benzodiazepines, followed by use of a spectrometer, a Fourier transform infrared spectrometer. That's this device down in the lower right corner. And then for that product, we're sending samples out to a lab out of state right now for GCMS. We are right now just launching 5 new light sites. With a full 7 sites, we have funding from the state to not just buy these $50,000 machines, but even more importantly, fund a full-time person to actually run the machine and do the work and provide harm reduction services. So the full sites are getting one of these FTIR machines plus a staff person. We don't have a funding to expand that yet. So we're trying a light model out right now where we're using test strips and actually working with another laboratory, the National Institute on Standards and Technologies, which right now is doing free confirmatory testing with mass spectrometry. And we will be doing work over the next year to look at the relative value and difference, essentially the test statistics of the full site versus the light site, both quantitatively and qualitatively. The resource burden is much lower. What's the quality of the information and value of that information that we're providing to folks? This is, don't worry, I'm not going to belabor this. Just letting you know, we have a really beautiful online dashboard that Jason Williams has built around what drugs are we seeing. I will note that about 1/3 of samples we're testing are showing methamphetamine, about 1/3 are showing fentanyl, and you can see some of the other components and constituents. This is specifically looking as an example about what we're seeing in fentanyl powder. What we're seeing in fentanyl powder is almost always fentanyl. We're often seeing manufacturing precursors. We're sometimes seeing other analgesics, that's acetaminophen primarily. We're seeing about 10% xylazine. That is a bit of an increase from what we've seen previously in powder, and it's a higher proportion than we're seeing in blue M30 pills, still well below the level that we're seeing in the East Coast around xylazine. So, and this is an example here actually from the medical examiner of a recent sample of a powder that was actually 83% fentanyl. So they're seeing higher quantification levels of fentanyl. We cannot quantify with our community drug checking network right now. We're doing qualitative results, just to let you know that. And this is an example of site-specific data, just sharing with them in the middle. Hey, of the 79 samples you got over the last quarter that were sold as, most common was methamphetamine, followed by fentanyl powder, followed by cocaine, followed by fentanyl pills. What was actually in them? And if you look here again in this lower left corner, these 22 samples with fentanyl powder, they all had fentanyl, and a handful of them also had xylazine. A couple had methamphetamine. And one of the things that we are working on is some additional contextual data to try to understand, and we are collecting these data, do people suspect that the substances were either cross-contaminated, that they stored them in a mixed product, that they purchased a mixed product? We're really trying to understand whether that methamphetamine is knowingly there or unintentionally there. So there's some additional contextual data that we're working to fold into our analyses. So as an example of the so what of drug checking, this is actually in Walla Walla, a wonderful example shared by my colleague Malia Lewis there. So they had a client come in and their fentanyl tested positive for xylazine. She provided harm reduction education to them about fentanyl and also education about what wounds might look like. There are fentanyl-specific wounds that can occur. They didn't have them, but she wanted to educate with them what they look like. They actually found those wounds within a couple of weeks. They came back to that agency, and luckily, we have a low-barrier buprenorphine project there, and we have a clinician there, and that clinician was able to initiate wound care for that client then and there. And then they were able to, from a drug checking network educational perspective, increase their vigilance and education about xylazine. So to me, that's kind of the power and the beauty of how all of these services can come together. I'm going to pause there, Joe, just for a minute. I'm about to transition off of drug checking. I don't know if there's any other questions that would be helpful to address.
No, there wasn't a question that came in, but to clarify a point, that the drugs that are checked by people bringing them in to this. Is that how it is? It's, yeah, people, okay.
Great question. Yeah, so very, very good question. So the drugs are getting checked by a drug checking technician. So some of these sites have handed out and continue to hand out on test strips for people to use on their own, but we're doing point of care testing. So we're doing point of care testing using immunoassay test strips and the FTIR, and we're giving those results and that feedback right then and there. And then we're getting confirmatory or secondary testing, really, oftentimes not for another week or two. We do our best to give the results back to that individual, and we definitely incorporate that information into our learning in our own quality improvement processes around the drug testing process and communication. And then we're also sharing that information. The results I just shared with you, I should be really clear, those are the results of the GCMS analyses. That's what I'm sharing at this point. These are really rich, really complicated data. There are multiple levels of data. There's qualitative and quantitative data, and we're just beginning to scratch the surface in terms of how to analyze and present them. So we're kind of in version 1.0 of that webpage.
Caleb, there's one more question about contrasting the full site and the light site.
Yeah.
Are there some additional advantages or values with the full site?
Well, I mean, the biggest advantage of a full site, I would argue, is paying a full-time person to do harm reduction services. And I'll mention as one of the sponsors of the state opioid overdose response plan and our recommendations around opioid settlement dollars. That group, it's myself, it is the Medicaid director, it is the chief science officer of the Department of Health, and leadership at DBHR strongly recommended putting substantial funding into harm reduction services. And that has not happened. And so I can't say enough about how important it is to actually, that harm reduction is about people in place. I think we think of it as about supplies. And yes, supplies are essential and important, but without people in place, you've got nothing. So I actually think what's really important about the full sites is the ability to actually pay staff. What we're seeing with some of the light sites is we're able to leverage essentially, for instance, public health nurses who are part of a health department, who have the ability to sort of leverage some other infrastructure. But a little teeny nonprofit syringe services program in a rural area, their ability to engage in drug checking, they might be open 2 hours a week, and they might be, have people lined up the entire time. So the ability to actually fund staff is really important, and it's something that we're also, really looking from a legislative perspective to try to encourage. Okay, I'm going to go through a little bit more here. I just want to let people know about, we have a treatment research work group that's been around for over 15 years. And it's what it sounds like. We're trying to advance collaborative research and evaluation to inform policy and practice. And it's co-chaired by myself and Michael McDonald, who some of you may know when he trained and worked here at the University of Washington. And he is at WSU, and myself were the co-chairs. And what's really exciting about this work group to me is it's substance use disorder treatment providers, both specialty addiction treatment and healthcare system based, as well as researchers. And it's always been those folks, although the healthcare folks are new. But what we've added in the last few years has been payers and managed care organizations, which is really exciting. In some ways, it's really important for us as researchers to know what payers care about and to make sure we're asking questions in a way that actually helps them make decisions about what they're going to pay for. Sounds obvious, but it's really important. They also have really rich data, and they have incredible internal motivation to analyze those data. And sometimes we can be of service and help them with those analyses and or learn from them. They can often move much more quickly than we typically can. So there's a lot to learn and work with in terms of those payers and managed care organizations. We also are inviting policymakers and state agency representatives, and we often are having 30, if not 40 more people at these meetings. And they're really exciting. I'll share with you our last meeting. We particularly focused on trying to co-develop a research agenda around methadone, how to expand access to methadone, how to understand some changes in state policies and funding about new models of accessing methadone, and understanding how that uptake impacts reach, access, and outcomes. So in terms of online resources, we have a broad audience. We're looking at the general public. We want to make sure we're providing information of value to people who use drugs, and also folks who are in healthcare, treatment, and first responder professionals. Our materials are kind of basic education. There's a lot of advanced education. We have a lot of basically everything we're developing around, for instance, our state overdose response and our regular ongoing webinars there. All of those videos are on the learnabouttreatment.org webpage, for instance. And then we have a lot of printable resources. Somewhere behind me probably is our shared decision-making tool for opioid use disorder for medications. We've printed over 10,000 of those brochures and distributed, and those are widely used. And we're actually in the process right now of Medicaid working to certify that decision aid so that it can be used more broadly. Just showing you here our stopoverdose.org webpage. There's a lot here. It's a really rich webpage. It is widely used. We launched this in 2011, right after we became the second state to pass the naloxone, the Good Samaritan law. So we've really been able to build out this webpage and have robust information there. It's heavily relied upon as a training resource for all sorts of professional organizations, and also just for the general public to find where they can access naloxone as naloxone becomes more and more available. We also have our learnabouttreatment.org webpage. It is focused on opioids and stimulants. So I just gave a talk last night in Susan Ferguson's conjoint class and really used this webpage where, for instance, we talk about what is opioid use disorder? What is stimulant use disorder? What are the evidence-based treatments? Here's an example for professionals around client engagement. What are the models and approaches? What about the legal system? For better or worse, that is where a lot of people are intersecting, and they are increasingly an access point to either provide care or continue, and we need to be supporting them to be providing evidence-based care. We're doing a lot of work now, a lot of formative work around young adults and adolescents, particularly around medication access for opioid use disorder. We have a learning collaborative that's running right now. We'd love for you all to join and participate in that. And then we also have information for family and friends. We get obviously all the questions you all get as clinicians about what is addiction, is it my fault, what can I do, should I try tough love, all of those types of things. So we have this webpage, which has become quite robust. This is just an example of our data webpage, really rich information by geography, by drug type, by multiple data sources. This is a little teaser diagram. This is a Venn diagram around what drugs are present with fentanyl when there's no heroin present. So what are the drug combinations we see in that instance? We actually further divide this by folks who are over and under 30. We see profound difference in co-ingestant profiles by age when it comes to fentanyl. So really rich information that I think could be informing, our educational as well as our treatment work. I've mentioned most of these things to just make sure we have a lot of things online. I'll also want to note in particular something that our recent but former colleague Lisa Ray Thomas helped build, a Tribal Sovereignty and Indian Healthcare System series. This is a 5-part series that is an amazing 101 in terms of understanding these systems and also the role of tribal sovereignty. Really essential for folks who are doing work in Washington State to be familiar with this history and understand how it impacts our care and our relationships now. Multiple community engaged projects. I've described most of them. I will note one more. I think it will be in May of this year will be our 4th annual Transforming Our Communities meeting. This is really a statewide harm reduction conference. We're careful not to co-opt that terminology. It's a grassroots movement, but we want to support and uplift those folks who are doing harm reduction and provide a venue for them to share that information. And then I encourage you to stay in touch. Please reach out to me directly, please. And then also we have a newsletter for our group. We also have the treatment research work group, and my colleague Susan Kingston has kindly volunteered to be a contact point if you're interested in getting looped in on that. We'd love to stay in touch with you and just be in touch and get your feedback and thoughts. So with that, I will pause and stop and see if we have any questions or comments. I'm happy to take those.
Caleb, thank you for walking through this research and your current work, not preliminary, results from the recent trial and so on. And not only that, but your rationale for making decisions, how you move to next projects and so on. It's, I think, very, very informative. One question came in, straightforward one. Is it possible to join meetings, still possible to join meetings for the Washington Treatment Research Group?
Yes, we meet quarterly. So I will try to do my best to cut and paste Susan's email address and put it in the chat so you don't have to do that.
Caleb, I will see if Mike can do that, so you don't have to type it in while talking.
Well, I multitask. Okay, great. Yes.
Okay,
Please join that group. And actually, I'm going to give a quick example of why that group is so meaningful to me. I sat in that group when I was doing my dissertation. And it was that point, it was just researchers and clinicians. And this is back in 2006. And the clinicians were saying, we're seeing these people and they appear to be addicted to pharmaceutical opioids. And they're coming into methadone programs and we don't know how they're doing. And that was my dissertation. So I just took that insight, that emergent need expressed by clinicians about how are people who are addicted to pharmaceutical opioids doing in this care setting that really grew around heroin. And the answer was, by the way, very well, thank you. They had very, very similar outcomes. But that was a nice opportunity to look at statewide data from 11 opioid treatment programs and use that for a dissertation. So we very much, I should also say, strongly invite students to participate in that forum as well.
I'd like to encourage others, if you'd like to write in a question, we have a minute or two to go through things. And I think, Caleb, as any questions are coming in, I'm wondering, you mentioned about payers as an example of, people that have opinions, ideas about research questions might influence a direction. I wonder, I mean, you involve a lot of people in research, and I think, I guess if you had to quantify or maybe to say a little bit, to what extent do your questions change from where you start and hearing from others, talking with others?
Yeah, very important. So I'll give a great example of that. So we believe, we hope and think that care navigators are really important. So if we think that, then we need to document their services and we need to test the impact. And so we actually are creating care navigator activity logs. And we're still working to analyze those data, but it's really important for us to see what's happening. And what we see in those care navigator activity logs is even during COVID, even during fentanyl, those folks working in low-barrier buprenorphine had substantial and frequent interactions with people who use drugs. And what was really profound to me is that one of the main things they talked about was people's current drug use. Even as they're on buprenorphine, they are comfortable, because of the dynamics we've set up, talking about their current substance use. That was not something people were comfortable talking with me about 28 years ago when I was doing my training in an addiction treatment program. People were very wary. They were wary of a punitive response or being judged. And so flipping this around, providing services in harm reduction organizations and sites, saying we're going to keep working with you no matter what, acknowledge that ongoing substance use happens, and that even with ongoing substance use, that treatment medications, methadone, buprenorphine, still profoundly reduce mortality risk and can still be a stepping stone to recovery. And recovery takes many different forms. So we get this piece about, like, from a payer's, like, well, you want us to pay for it? Well, what do they do? And what's the added value? It's also really helpful to say, this is how you staff. This is the personification of harm reduction. Our care navigators. And this is what they do. One of the things they do is called emotional support. It's not counseling, it's emotional support. And it's one of the main attractions and the glue that keeps people coming back.
Well, an interesting example from that research finding and the direct clinical implications as well. Well, I think, Caleb, here we are just at 1 o'clock. I think it would be interesting to continue going through more questions. I'm sorry we couldn't get to everything that it came in for those who wrote in additional questions, but we are at 1 o'clock and we'll have to end for today. So Caleb, thank you for the presentation today.
You bet. Thank you so much. Hope everyone has a great afternoon and weekend.
Okay, thank you. And we'll end
Bye.
grand rounds there.